Thank you very much, Dr. Srinivas, and the team for inviting me for this beautiful event of Balance Con. It is a Kumbh Mela of people, those who love vertigo. I'll restrict my talk to the raised intracranial pressure and vertigo, the conditions those which are responsible for causing vertigo. As you all know very well, approximately 500 milliliter of CSF is created, form every day, and it drains through the subarachnoid. It is secreted by cranial plexus and it is circulated in the subarachnoid plane. Brain has approximately 1400 ml substance, blood is 100 ml, CSF is 100 and up to 100 ml. All these three components, compartments are non-compressible, and any change in the volume of one of these, any change in the volume of the brain causes reciprocal change in the volume of one or the other two compartments. This is called as Monro-Keeley doctrine. This is the same thing. There are different terminologies that are used for raised intracranial pressure. One is the increased intracranial hypertension syndrome, idiopathic intracranial hypertension, pseudomotor cerebri, pseudotumor cerebri, benign intracranial hypertension, or normal pressure hydrocephalus. Nowadays, this term idiopathic intracranial hypertension is more preferred. There is a raise in the intracranial pressure. It is a serious medical problem. The pressure itself can damage brain or the spinal cord by pressing on important structures or by restricting blood flow into the brain. There are different factors those who cause raised pressure. One is the rising pressure. There is an increased pressure in the brain matter. There is a bleeding into the fluid that surrounds the brain, and the swelling of the brain matter. Increased ICP is a syndrome that affects many patients with acute neurological conditions, and elevated ICP is most commonly associated with head injury, secondary effect to the other conditions like subarachnoid hemorrhage, toxic and viral encephalopathies. Increased ICP from any of these causes can decrease the cerebral perforation, stimulates further sort of a swelling or edema, and shift the brain tissue through the different openings of the rigid dura, resulting into the brain herniation, and frequently this can be fatal. As it is shown here, these are the main factors, those who are causing the trouble. There is a obstruction to the flow of CSF anywhere can give raised intracranial pressure. What are the factors that influence increase intracranial pressure? Is arterial pressure, venous pressure, intra-abdominal and intrathoracic pressure, postures. There are temperature also, it affects blood gases, especially raised CO2 levels. The different methods are there to use intracranial pressure. The easiest is by doing lumbar puncture. You can do put a needle in the ventricle. There are different sensors, and now newer methods are available, safer methods to evaluate the pressure. What are the effects? These effects are because of compression and distortion of the brainstem, and they are noticed in the patient, those who are critically raised ICP, and it is found also in the experimental animals. What are they? There is a decrease in the respiratory rate, bradycardia, cardiac arrhythmias, pulmonary constriction followed by unilateral pupillary dilatation, increase in the pulse rate, and increase in the arterial pressure. There are different symptoms which occur because of the raised pressure. They can be either more in the morning, associated with vomiting, and there is a pain because of sensitive structures, they are getting stretched. There is headache, and sometimes because of the raised intracranial pressure you see papilledema. These different effects which occur because of raised ICP, I will not go into details. The brain herniations are known. What is the medical line of treatment? there are different modalities are suggested, like there is a sedation, positioning of the patient, and hypertonic sort of solutions of mannitol, furosemide, glycerol, steroids. There is a hyperventilation treatment. Hyperbaric oxygen also has been tried along with hypothermia. And then there is a entity which is barbiturate coma, where patient is doped. I'll restrict myself to this particular topic, which is of more interest to ENT people. This is idiopathic intracranial hypertension is a syndrome in which the intracranial pressure increases without any hydrocephalus or a space occupying lesion. There is no pathology as such. After a prolonged search, I could see one article, this audio vestibular findings by Professor Koban, and they have noted quite a few good things which can be beneficial to us if we want to pursue further studies in this particular topic. This syndrome was first described by Dandy in 1937, and later it was modified by Smith. This is a modified Dandy's criteria. And again in 2002, Friedman and Jacobson, they have modified a few of the criteria. What are the criteria? The signs and symptoms of raised intracranial pressure is a normal neurological examination except 6 nerve abnormality. The raised CSF opening pressure is 250 millimeter of water or above, but the CSF examination is normal. There is no evidence of hydrocephalus, there is no mass or any structural or vascular lesion on imaging. And there is no other cause is identified for this particular entity. The etiology is still obscure. Currently, 3 major theories are postulated. It is one postulate is there is an increased resistance to the absorption of CSF. Another is increased production of the CSF. And third is increase in the venous sinus pressure. As I have told you, numerous terms have been used to describe this particular condition. Idiopathic intracranial hypertension, pseudomotor cerebri, then benign intracranial hypertension. But IIH, this is a term which is nowadays it is quite accepted. What is the trouble? Whenever there is a raised intracranial pressure, like we all know very well, when there is a raised intracranial pressure, we see optic nerve is damaged and we see papilledema. How it occurs? The increased intracranial pressure is transmitted through the nerve sheath directly, and the result is swelling of the optic nerve fibers. Because of pressure, the exoplasmic transmission in the optic nerve is affected. A similar postulate is suggested by Giuseppe that because of the pressure there are problems over the nerve endings and there is a pulsatile tinnitus. Ludwig and Sisman, they have suggested that hearing loss is a result of the masking effect of the tinnitus. The pathophysiology of tinnitus and hearing loss is not very fully explained up till now. But another reason which is thought to be is transmission of the raised intracranial pressure into the perilymph through cochlear aqueduct. By this, the tension of the basilar membrane is increased and the mobility of the footplate of the stapes is affected, causing hearing loss. There are very limited studies available in literature about investigations related to audiovestibular symptoms and signs. It has been observed that both cochlear and vestibular organs are primarily affected in this condition. There are definitely a lot of gait anomalies are noted and there is a difficulty in walking. The other series of raised intracranial pressure where the gait abnormalities are more, lot of references are found in neurosurgeons journals and all. They have got very good results when they do the shunt operations. The transmission of the increased cerebrospinal pressure to the cochlear aqueduct and internal artery canal, it causes compression or increased tension in the cochleovestibular nerve and endolymphatic system is a main pathophysiological explanation for this particular entity. The another possible mechanism for vestibular symptoms may be the endolymphatic fluid malabsorption as a result of direct compression or decreased vascular supply of the endolymphatic sac, which is wrapped between the two leaflets of the dura. There are a lot of mentions about the WEM being done in these patients. They show decreased or increased amplitude, the prolonged latency, absence of the WEM responses. The result is suggested that the intracranial pressure may affect inferior vestibular nerve and saccule. The saccule is a membranous labyrinth that is filled with endolymph. It is located in the bony labyrinth which is filled with perilymph. And the endolymphatic sac responsible for the absorption of endolymph is connected to the utricle and saccule via endolymphatic canal. Pressure alteration in each of these locations, they are transmitted directly or indirectly to each other. The saccule is the second most common site where there is an involvement during the endolymphatic hydrops. The increased endolymphatic pressure dilates the saccular maculae, which results in delayed WEM responses. It is known that especially the decreased amplitude or no response of WEM may be associated with the endolymphatic hydrops. The different investigations which are done in the series of Professor Kumar, they are pure tone audiometry, tympanometry, vestibular evoked myogenic potentials, and ENG. Now we have got better gadgets like balance eye. We can definitely go for investigations like VNG, VHITS, and craniocarpography also can be planned in these patients because they have got a lot of gait abnormalities. Thank you very much.
Thank you very much, sir. I know how much effort has gone into that, how much he has spoken to many neurologists. He has dug the literature, found anything. He has put in a lot of effort because this is one topic which is not routinely covered in the literature. Thank you so much for all the effort that you have put in. Thank you, sir. Thank you, sir. Thank you.
I just have a comment.
Yeah.
There is a comment. Thank you very much for this interesting topic. I have seen few cases with no other detected presented by dizziness, but we couldn't find any other abnormalities except of the benign increased intracranial tension. So there usually they show some vertical nystagmus, especially upbeating nystagmus. This is what we see. Regarding the mechanism, how they work, I don't believe it's because of the endolymphatic hydrops, because the CSF is linked to the cochlear aqueduct with the perilymph, not the endolymph. So if the pressure increased in the perilymph, that means more compression, not hydrops. And this is supported by few reports about secondary endolymphatic hydrops due to low CSF pressure. And I have faced two cases after spinal epidural spinal anesthesia or lumbar puncture. They developed secondary endolymphatic hydrops because pressure in the CSF is low. Low pressure also will be in the perilymph, which causes expansion of the endolymph. So in my opinion, in my humble opinion, increased intracranial tension can be presented by dizziness, and I have seen this many times. And sometimes they show some central findings, especially like spontaneous upbeating nystagmus. And I don't believe that is the mechanism is due to endolymphatic hydrops, because increasing the pressure in the perilymph should compress, not to expand the endolymph containing membranes. And I do believe that the mechanism are mainly of central origin. The last point that as a clinicians who faced acute vertigo, be very careful because I have seen this practically and clinically. Sometimes patient with posterior fossa stroke presented by acute vestibular syndrome, which sometimes completely mimic peripheral vestibular neuritis. And just 1 or 2 days, they start, because of the cerebellar hematoma, they start developing signs and symptoms of increased intracranial tension. So please pay attention for those presented with acute vestibular syndrome. If they started to have some projectile vomiting, they have unexplained headache, because sometimes it occurs secondary increased intracranial tension because of the cerebellar hematoma. Thank you.
One thing has happened when Dr. Srinivasan, he asked me to prepare this particular topic, and I started meeting my neurosurgeons and neurophysician friends. Many of them said, why you? This is not a topic in ENT domain. But I said, no, I have been allotted this particular responsibility. And now, those people are ready to share their patients to us for getting the vestibular assessment done. That's a good thing that has happened. Thank you very much.
Thank you, sir. Thank you so much, sir.
Just because you said patients are being sent to you, if you speak to Dr. Gupta in PGI, he is doing fenestration of the optic nerve area to release pressure for vision abnormalities in benign intracranial hypertension. So just to tell you that if you contact the ophthalmologist or neurosurgeon, whenever you have benign intracranial with loss of vision, there is endoscopic surgery available for that. Sunil says it's not proven, but Gupta seems to be very happy with his results.